do you think that, obviously this is a very big and intricate contest and concept for us to grasp, obviously, because we haven't really worked or seen it or touched it by hand, but obviously we were talking about undermining maybe feelings and emotions, and that's why it's moral support that someone needs. So how would you suggest, if maybe we have a friend or a family member that we see that's different and is going through something traumatic, or maybe is feeling a little bit depressed or anxious, how do you suggest we would act, and what's the course of actions we, as maybe someone who's close to them, can help them go through this tough time, especially because, as you can say, we can just snap out of it?
Well, I mean, there really aren't, every time that, a country has become interested in trauma, I was, asked to go give a lecture there. So, at a certain point, Japan, decided that they had a history of trauma, or, Portugal, and it's usually like one event, England, with the Falkland Islands. So, I mean, the kind of knowledge of PTSD and trauma and the effects on mental health is, pretty widespread now. But, 30 years ago when I was starting out, it was considered to be only restricted to veterans of the Vietnam War, which is not accurate. So all the research that's been done shows that the prevalence of PTSD and stress-related mental disorders like depression is fairly equal in all countries. It's not only located in one country or in one population. There's probably 5 times as many civilians in the United States that have PTSD as those that have PTSD from the military. And probably the best and the treatments for PTSD are not as good as people think they are. So, like for depression, we say that with antidepressants, you get an increase of about 2 points on the Hamilton Depression Scale over placebo, which is about maybe a 15% increase over placebo, and that's fairly consistent. So for trauma, I don't really do, my clinical work is part-time. I work for the Veterans Administration in the United States, and it's primarily, medication related. I don't do a lot of psychotherapy myself, but I think that for trauma, probably, well, the evidence is that a combination of either psychotherapy alone or psychotherapy with medication sometimes is the best approach. And really it's all about talking to a third person who's independent and in a supportive environment. And one of the best predictors of outcome is whether the patient feels comfortable with the therapist, number one, and number two, whether the therapist believes that the treatment will help them. And it doesn't matter what kind of treatment you're giving it, whether it's cognitive behavioral therapy or, insight-oriented psychotherapy or, interpersonal therapy. And I think that probably the best element of recovery is just being able to talk about the traumatic event. And I tell people, you have to keep talking about it over and over until it sounds like it's a broken record.
Okay, thanks. Now Ettore is going to ask a question.
You are the author of the book Guiding Clients in Recovery from Psychological Trauma, which is a guide to allow mental health professionals to teach their clients to take charge of their recovery from psychological trauma. Is there a kind of new approach for PTSD which was triggered by the pandemic, or maybe the approach is exactly the same for let's say every kind of PTSD uncorrelated by the factors which cause it.
Yeah, so everything that we know is that regardless of the type of trauma, the mental health reactions are usually similar, the same. So there's no PTSD that's specific to combat trauma or to child abuse or motor vehicle accidents. The reactions are similar. You have intrusive memories, feeling worse with reminders of the trauma, avoidance, sleep disturbance, hyperarousal, and negative cognitions of yourself and of the world. And the rates of so we have mental health disorders arising from the isolation of the pandemic, and which include depression. We also have psychiatric disorders coming from having COVID itself, especially like if you look at people who've been in intensive care, the PTSD rates are very high, maybe 25%. And we know from previous research that you can get PTSD from having a myocardial infarction, having a heart attack. So there's rates of PTSD close to 25% from having a heart attack that required coronary care unit hospitalization. So being on a ventilator, being sedated, being in the hospital for long periods of time, that is a traumatic event, equivalent to being in combat. And we're seeing people who are having long-term neuropsychiatric consequences of that, of intrusive memories related to being helpless on a ventilator. A lot of times people were sedated and immobilized. There are also people who are reporting psychotic symptoms, while they're in the on ventilators, and we don't know how much of that is from the mental experience of being in intensive care, and how much of it is from the direct effects of COVID on the brain. There's certainly activation of the inflammatory response, which include interleukin and other cytokines. So we know that cytokines, so when you have an infection from, bacterial infection, you have a reaction of the inflammatory system, interleukin 6 and macrophages and other pro-inflammatory cytokines are released. One of the things we discovered that both in PTSD and depression, there's an increased inflammatory reaction. And so it's kind of curious why that would happen in the absence of infection. One idea is that the inflammatory reaction occurs to, with the inflammation, you get depressive-like behavior. So you get a decrease in movement and mobility. And one idea is that that's an adaptive response to conserve energy so you can survive and recover from the infection. Another idea is that there's an adaptive value to having an inflammatory reaction to stress, because maybe in primitive societies, when there's a conflict, maybe between two people, and there's an inflammatory reaction, if that was a predecessor to an actual physical conflict where someone's going to get injured, maybe someone cut with a knife, and you release a bunch of inflammatory factors, then that would help you survive the infection that came after being cut with a knife. So that's another idea. But I mean, in any case, it's pretty clear there's a large 2- or 3-fold increase in, especially with stressors, especially, when we record like a traumatic script, we get this huge increase in IL-6. And also when we have people do public speaking tasks where we ask them to give a speech with negative feedback, which is what we call mental stress, there's a huge increase in PTSD patients, more than in normal people. So we have this inflammatory reaction, and the cytokines feedback on the brain. They actually, affect brain function. And so a lot of the symptoms of PTSD and depression, we think, may be coming from cytokines, and not necessarily arising only in the brain. So in psychiatry, we used to just think about everything from the neck up, so we were always focused on the brain. But now we're really looking at these disorders as disorders of peripheral sympathetic and inflammatory function. And we know that there's, increases in sympathetic function which cause increases in heart rate and blood pressure. We documented that, and this is work that my wife, has done, Viola Vaccarino, using cardiac PET imaging to document an increase in cardiovascular disease and PTSD. We looking at twins who are discordant for PTSD from the Vietnam War. And so it's clear that they have an increase in cardiovascular disease. Previously, it was mainly focused on that depression is associated with increased cardiovascular disease, but in PTSD, it seems to be even more. And so these cytokines will feed back on the brain. And we think that there may even be activation of glia in the brain from the inflammatory reaction in COVID patients. Although the research hasn't really been able to correlate inflammatory cytokines in the long-term aftermath of COVID with these neuropsychiatric symptoms. So it's still unclear, whether it's an inflammatory reaction in the brain or whether there's other things going on. It could be the psychiatric symptoms could be secondary to long-term increases in peripheral cytokines. So, but it's an important area. But the one thing that's clear is the prevalence of the neuropsychiatric consequences of COVID is pretty high.
Thank you, Mr. Bremner. And next question from Giulio, Siena.
Yeah. So, do you think that maybe more fragile people that maybe also had recovered from a case of depression are maybe more inclined to have a setback during the pandemic?
Well, we know from studies in PTSD that previous psychiatric illness is a risk factor for subsequent development of PTSD. We also know in depression that if you have one episode of depression, your risk of having another episode is increased. So there does seem to be this sort of repetitive risk. One idea is sort of this idea of sensitization, that actually having an episode of depression kind of resets your brain and makes you more vulnerable. So I'd say that my guess would be that if you had a history of depression, your risk of having depression related to COVID would be increased. I don't know if anyone's really studied that yet, so these papers are just sort of starting to come out now.
Okay, perfect.
Maybe the last question, and I would like to ask that this question that maybe it's kind of odd, but do you think that maybe with knowledge, obviously with people always knowing about it and always maybe getting informed about mental health, which is a great thing, do you think that maybe people would start misusing the word PTSD or depression when maybe someone is sad, okay, but just one day or something is not really that important, and someone misuses the word depression or PTSD, which is kind of more important, it's a disorder for itself, so maybe even teenagers using it improperly?
Well, I think that, the use of these sort of mental health terms in popular culture is, it's already there, right? So people say, oh, I'm depressed, or, I have PTSD from this or that. I don't think it really matters, it's just sort of a form of, expression. People don't go to a psychiatrist unless they're desperate, usually. So there's nobody really over this kind of, we don't really see that people overuse psychiatry. I mean, maybe in more affluent communities that might be possible. I mean, I've not really, I work in the VA, so we only see people that are, it's sort of like the public health system. But, for veterans, so if a veteran was wealthy, which is unusual, but if that were to happen, they would probably go to they would probably have private insurance. It wouldn't go to, people don't go to the VA as their first choice of treatment, even though, I mean, there's people like myself who are professors at university who, because of the way the American system is set up, that, we have the opportunity to do research, so we're more likely, if you're in an academic setting, to want to have a clinical appointment there. But so most people don't, and there's a shortage of psychotherapy available even in the United States. So people have a difficult time, finding therapists and finding psychiatrists. There's a shortage of psychiatrists. And usually people don't go to psychiatry until they have a crisis, until someone tells them that they have to go, or, maybe they have something related to their work or their family that they feel like it's their only option. So I don't, just the use of, as you say, like, I guess teenagers saying words like depressed, that's just part of popular culture, but I don't think it really has a negative impact on people getting treatment for mental disorders. I mean, mental disorders are very prevalent. Probably 20% of people, have a mental disorder, and that's impairing their function, or a substance use disorder. It's a lot more common than you would think, because of course people don't popularize it. And it's kind of a curious thing, like why don't dogs have 20% mental disorders, right? Or why don't cats have mental disorders? And it's unique to humankind that we have this frontal cortex that allowed us to have the capacity for language and tool making and abstract thought. And it's the frontal cortex that's responsible for having mental disorders as well. So it's sort of like a byproduct of evolution, that our ability to think in abstract terms, also makes us vulnerable to vulnerable to having mental disorders.
Okay, thanks so much for your time and your availability. We appreciate it so much for giving us the opportunity of knowing the subject even better and this topic better, so we can talk about it and actually know what we're talking about. So thanks so much.